thank you. Can you hear me? Yes or no? You are okay. Okay, well, thank you, Ahmed, for the nice introduction. The topic, as you can see, it is clinical risk and governance. And I think anybody deals with patients, either clinicians, managers, quality sort of related issue people, they need to know about. Yeah, okay. They need to know about the issue of clinical governance and clinical risk management, because the fact is that we are dealing with a high risk population basically because they are coming in as patients. So they are not normal, healthy individuals. They are obviously sick patients. So we need to be proactive in terms of dealing and expecting how can we manage these known risks and problems. Okay, so yeah, this one? Yeah. So these are the things which I'm gonna address. A bit of background about clinical governance and risk management. I mean, basically they are both interlinked. Clinical risk itself, clinical governance, and how to reduce mistakes. The bottom line and the ultimatum is how can we reduce risk and keep patients safer. So since I started my interest in medical management and risk management probably 20 years ago, I found this quotation by Mahatma Gandhi. Maybe you can say, well, what Mahatma Gandhi got to do with medicine and risk management, but you will see. So what he said, a patient is the most important person in our hospital. He is not an interruption to our work, he is the purpose of it. And he is not an outsider in our hospital, he is a part of it. And we are not doing him a favor by serving him, he is doing us a favor by giving us the opportunity to do so. So basically, in a nutshell, this is what we mean by sort of patient-centered care and clinical governance, risk management, how to make the patient is the center of our attention and the reason for our sort of work. So Mahatma Gandhi, I think probably when I looked into his sort of date of birth and when he died, I think he was born in 1890 something and he died in 1949. Sorry? Okay, thank you very much to be accurate. But obviously, I think what I'm trying to say is that the clinical governance issue, it all started really in the 90s. In the West, in UK, States, and so on. Before that was very primitive. And in the 90s and after that, people started talking about patient safety, clinical governance, how to make the patient the center of our attention, and all of that. But look back at this man. He exactly discussed and attended to what we are talking about. This is at least 100 years ago. So, I mean, when we talk about risk and how to make patients safer, this is, for example, examples. There are only a few examples, and this has happened all over the world. I mean, I'm sure all of us who practice medicine, see children and others, we come across a few cases where we felt that maybe we could have done better. I mean, this is, for example, a series of errors killed cancer injection boy. Another one, deadly errors series of blunders killed Wayne, who is 18. And the other one, girl, she's 3 years old girl, killed by oxygen blunders. These high-profile cases, how this all started, there are more examples. I mean, this Victoria Columbia, this poor girl who, I mean, sort of attracted the attention of the media probably 15 years ago, or around that in UK. This girl, sort of a normal, happy girl, she was in Nigeria. She thought she was gonna have a better life in London, but it turned out to be a disaster. Because I mean, her auntie is the troublemaker, but we doctors, nurses, health professionals, we failed to protect this child. She came to the hospital many, many times, and nobody could pick up the problem, nobody could save her. A child with the child abuse, many times she needed admission to the hospital, needed to be protected from the abuser. More examples, this sort of docs removed their wrong kidney. Again, this is not an unusual example, unfortunately. We heard all about it before. Dr. Sherman, this is another story. Who GP, single-handed GP, who probably murdered more than 200 patients on his own over maybe 15, 20 years. More examples, Bristol baby heart surgery report, a profession in crisis. That's how the media presents it, and this is to irritate the public, will agitate the public, and the public will put more pressure on the governments and the decision makers. So death toll maybe more than 140. Again, this is how things work. The media, I mean, initially probably if people heard all these news, nobody will take notice. But because of all these stories, the media sort of keep this because they want to attract their readers, make more money, so bring sort of the news that will attract readers. So that's how it works. But unfortunately, or fortunately, it will put the pressure on the government, so they have to make something. Okay, so I have to go back. Yes. To be a bit more objective rather than just depending on the media sort of stories, 3 big famous studies were done sort of a few years ago, and one in the States, another one in Australia, and the third one in London. And basically, the conclusion is there are patients who are admitted with no risk of death. Yes, they are sick for whatever reason, they brought to hospital, but no expected death. Okay? So when they analyze it, they say, for example, the first one, 154 died. Out of this more than 30,000, this is really for no reason and purely after investigations because of medical or clinical blunders, drug errors or whatever. So basically, this is unavoidable deaths. And these are very objective, and we are not just talking about the media highlights or the stories that attract the media. Okay, so even closer here, in our own country here, obviously the decision makers and the Federal Nation Council, everybody sort of knew and they sort of confirmed that this is a real problem even here. So the medical errors and neglect killing patients in UAE, and this is a fact. So we said earlier at the beginning, they said we are dealing with high-risk patients. They are not normal population. So how risky in the reality, to be objective, and if we compare our profession with other professions, so we can have a fair judgment and assessment. If you look at risk of fatal outcome per exposure per profession. Okay, if you think living next in nuclear power station or working there is serious and dangerous, that's really not the case if you compare yourself with a hospital admission. Just the fact that you're admitting a patient in a hospital increases the patient is at risk of dying tremendously. So from ultra safe, acceptable risk, and dangerous, and a very high risk and high chance of dying because of just a pure admission, regardless of your underlying problem. Again, if you look at the total health expenditure per capita, this is obviously probably 10 years old or more, but the fact is that we look into the change in expenditure, what the decision makers, what the government sort of invests in our service. It says that just say, if you look, this is an example in Ireland, and say from 1,500 to over 3,000. Is it by dollar, is it by euro, a pound, Irish pound, whatever. But this is because of the increase in expenditure then there are consequences to this. Okay, increasing investment demands better performance. People giving their money, they expect something in return, and something good, not just something. Okay, so complaints are increasing. And this is a fact as well. And is it because increasing expenditure? Okay, and increasing public awareness, this is true, I don't need to explain this. Increasing public and government expectations, because the public know everything, they come to the clinic ready and they know everything and have a list of questions, so they know what to expect. And the governments, because they make decisions, make rules, guidelines, and all of that, plus they spend the money, so they expect high quality and high level service in return. And the question is, why do we make mistakes? I don't know if anybody has an answer to this. I don't think there will be an easy answer. Some of the previous cases investigated and studied, and in conclusion, this is one of the comments in the outcome. It was a simple procedure using a simple piece of equipment. The consultant anesthetist had performed the procedure 1,000 times before, but this had been a particularly busy week. He was tired. He was preoccupied with something else, a family problem or whatever. He was even carrying a bit of flu. So when we do have a problem, I think the reality and the fact of the matter is that people, it is a combination, maybe small things, few things together, end up with a disaster. Okay, well, some people say, well, risks have to be taken to develop more effective treatments, interventions, especially in the surgical and intensive care. And for us to develop, you have to take risks so that you succeed this time, and next time becomes a normal routine practice. That's the fact of, this is a fact of life. Or is it the very nature of healthcare is a risky activity? Because as we said earlier, you are dealing with a high-risk population and sick patients, and sometimes very, very sick. So what to expect? I do my best. Okay, so inquiries in the past, obviously many inquiries in various countries and at various levels, some of them concluded the following. And we always talk about communication and poor communication, and this is a fact. And all of us, every one of us knows that. So, poor communication with patients and families, this is a fact. Poor clinical and managerial leadership, poor communication within a clinical team, say consultant to specialist or registrar to CHO or GP to however. We need obviously to have a clinical sort of communication pathway clear that it is known to all of us, so we do it properly. Poor incident reporting, monitoring process, and a clinical audit absent. This is their comments, and I think we agree, or we should agree. No system for assuring and maintaining competencies. I mean, I think this is obviously, again, competencies. When clinicians, doctors, or nurses, or whoever work outside their competency circle, they're actually putting the patients at risk, definitely. That's why we have privileging competencies and so on. And many services like independent regulation and inspections, for example, like GCIA. And this is meant to be to improve our quality of care. Independent assessor comes and looks objectively to our sort of service, and they give us their conclusion and their recommendation at the end. And what do we need to improve on? So, weak and ineffective governance, that is what it's meant to be. If you all have these problems, then your governance system doesn't work or needs to be sorted out. So, what do we mean by clinical governance? I think this is all of us, we probably heard a lot about it, but maybe our understanding is variable on this. Maybe it means different things to different people, but in a sort of conclusion, this is a system through which healthcare organizations, i.e. hospitals, are accountable for continuously improving the quality of their service and safeguarding high standards of care by creating an environment in which clinical excellence will flourish. I think it's self-explanatory. Okay, clinical governance is about ensuring that patients are safe and the risks are managed properly and lessons are drawn and learned from these experiences. So in brief, just in summary, what do we mean by clinical governance? And they are multifactorial. There are so many factors, they are interlinked, and each one is dependent on the other. We cannot have 4 or 5 and leave the rest. We have to have everything, because otherwise we still have problem. You have clinical audit. I mean, really, I haven't seen it done properly. Maybe you have a small department of clinical audit. They do certain things. But the clinical audit subject, the way I know it, and the way that should really have an effect on the patient care is still in the early stages. Clinical effectiveness, risk management, use of information, in educational training, staff management, and patient involvement. These are all important factors, and they need to be there in the working place. Clinical audit, I will touch on this briefly, just because it is important. It is a quality improvement process that seeks to improve patient care through systematic review of care against agreed standards. You have international from professional body, a guideline, you assess your care, the type of care that you are doing, and then compare it, then conclude whatever recommendations, and then re-audit again. That's what we call the audit cycle. Clinical audit and risk management. Clinical audit should answer a patient, are patients given the best care available? Are they exposed to the lowest possible risk? That with the proper management, with the highest sort of, or the most recent guidelines, patients are given the best care, and they should have less risk and best care available. So risk management, I think this is what we mean by risk management, is the process of assessing the probability of an adverse incident, taking steps to reduce the risk to an acceptable level. We cannot eliminate risks completely, but we need to continuously try our best to reduce it to the minimum. So clinical risk management is an essential part in implementing clinical governance and is required by all our professional bodies. Let it be the regulatory bodies, patient insurance. If we are not doing our best and managing our risk properly, then we will have a lot of rejections with our claims, and maybe our insurance will be, our personal insurance will not be sort of valid. Anyway, risk management, again, it is, as I said earlier, it is dependent on the infection control, incident reporting, the workload of the doctors or the nurses need to be within acceptable. If you ask them to do a lot of work more than what they can do, or the clinic template or whatever allows them, then you are putting them at risk. Support audit, and then feedback of the team involved. They need to know what is going on and what are the problems, what are the lessons, and how can we improve. It is a teamwork. Okay, clinical risk reduced by clinicians should practice within their competencies. This is important. We shouldn't be doing anything different or what we are allowed to. Credentialing, evaluation of qualification using official transcripts. This is for, I think, here we are done by the data flow and others, but it really needs to be done properly, and it is a problem in some other countries. Okay, appropriate credentialing, as mentioned, privileging appraisal process. Appraisal process is important, and I think needs to be done appropriately to be effective. If we need to benefit from the appraisal, then it has to be done properly or no need. Clear job descriptions and job plan. Job plan means what is your workload, morning, afternoon, whatever it is. So it should be assessed, and that's how we assess your performance objectively. Clinical risk reduced by effective quality of care delivery, effective handover. I mean, in all these, what is in the list here, whatever it is mentioned, and whatever we do in our day-to-day, the morning handover, the night handover, the ward rounds, all these things really should be done properly so we can keep risks under control. effective incident reporting system. The staff need to know. We talk about incident reporting, but some people don't know what sort of incident that I need to report. And how do I do it? How to complete the form? And what happens next? Incidents are investigated, feedback given to the person involved, but also in confidence to the rest of the team. So you don't need to go through every that incident yourself to benefit from these things. We need all to benefit from any experience, so we all learn. Okay, clinicians should raise and voice their concerns when standards are being compromised within reason. Okay, continually strive for quality so as to promote and safeguard the interests and well-being of patients, and report unusual incidents to prevent or minimize future risks. Okay, I think guidelines are very, and there too, when you have proper guidelines, most recent guidelines, guiding good practice, and you are delivering high quality service, then definitely patients will be happier and at less risk. Okay, patient involvement. Patients in their journey through the healthcare system are entitled to be treated with respect and honesty, and to be involved wherever possible in decisions about their treatment. And this is done in the Kennedy report in 2001, and more or less similar to what Mahatma Gandhi 100 years ago. So, and this is what meant also patient-centered care. So I think in conclusion, healthcare is a risky profession, changing quickly, and that's why we have to be keeping up to date. Patients deserve best care wherever they are. Not if you are a tertiary hospital, you get everything, and if you're a small medical center in Wagan, you get less quality of care. Healthcare facilities to ensure adherence to regulatory bodies, so whatever Department of Health or DHA are recommending for whatever practice inside the hospital or outside the hospital, it has to be implemented fully. And the other thing is most clinical risks and complaints are avoidable, encouraging transparent, open, and no blame culture. Clinical audits are essential part in the clinical risk management. And I think, thank you, that's the final.